So good morning, everyone, and thank you for joining us today in our
I can't hear you.
Rafa, you lost sound.
Can you hear me now?
Yeah.
Okay, sorry about that. So I was saying that good morning, everyone, and thank you for joining us in our international rounds. That is my great pleasure to introduce Professor Lee Benson, who doesn't need an introduction. So Dr. Benson is a well-known interventional pediatric cardiologist who also works in the adult world and is one of our interventionists here at the Toronto General. And what Dr. Benson is going to talk about today is one of his passions, is how to deal with large outflow RVOTs and what is the role of the new valves in this setting. So Lee, I cannot think of anybody else better than you to talk about this. So thank you for joining us. Thank you for agreeing, and the floor is yours.
Thank you very much. Let me just share my screen. Can you see the presentation?
We cannot.
How about there?
No, we see the GoToMeeting screen.
Oh, because it said I'm sharing here. All right.
You're sharing your screen, but do you have two screens?
Yeah.
Okay, you're sharing the other screen.
All right. Let me just do it differently.
There you
Can
are.
you see me? You can.
Yeah.
Okay. Okay.
Yes.
Okay. Now.
We see this. We see the slides. We don't see the presentation mode. But if you go in presentation mode, we should be able to see it. We see PowerPoint. We don't see the presentation mode.
Oh. All right. Well, let's try it again. Technology.
Yeah, it's not here to help.
How about now?
No, we still not seeing the presentation mode. So are you sharing a screen or just sharing application?
No, I'm sharing the screen. Let me just do it again. I'll be done with the. All right. Okay. It should work now.
Okay. I think that's gonna work. I think that's going to work. Yeah. Okay. Perfect. We are seeing the disclosure as well. Yeah. But you are in the. Just change the display. There you are.
Okay.
Okay.
Good.
We are seeing the disclosure.
Okay. Thank you very much.
Okay.
So the learning objectives for this morning to talk about management of the large right ventricular outflow tract is to understand the anatomic boundaries for the use of percutaneous valves, for you to become familiar with various valve designs and their mechanism of action, and update on hemodynamic anatomic outcomes of the existing percutaneous valves that are in clinical use. So percutaneous pulmonary valve technologies have become, well, a game changer in the way we think about the management of congenital heart disease. And what I'd like you to think about as I talk this morning is how has this impacted strategy for care for our patient population, develop an understanding of what the boundary conditions are for screening patients, and a consideration of what the various valve designs are and which valve design may be more appropriate for a certain outflow tract anatomy. Now, I guess perhaps because I'm late in my career. I'm always interested in looking at the history of where we came. I always feel that that's a way to understand where we are and where we're going. And the first intervention on the right ventricular outflow tract was actually in 1955 by Rubio and Lehman Lassen, and they were Mexican cardiologists who did this procedure on this young girl who had pulmonary valve stenosis. And this was a urinary catheter, if you could believe that or not, and that they put a wire in, and they put this across the pulmonary valve and sawed the valve open. As I read this, I always wondered how it would do in our IRBs today with this kind of technology. But the real intervention on the right ventricular outflow tract, which began our profession of interventional cardiology in a significant way, was that of Gene Kahn and Robert White at Johns Hopkins University, where they described pulmonary valve dilatation with a balloon angioplasty catheter. This is Gene and the first patient. Her last name was Owen, and for those of you who remember doing these procedures in the mid 80s, it was the Owen balloon dilation catheter that we bought from a company called Meditech that made these. So she had named the catheter after the first patient. The real technology for percutaneous valves, however, began in the late 1980s with Henning Anderson, who's pictured here. He's a young interventional cardiologist, adult cardiologist, who felt that there was a better way to deal with valve disease, and he came up with this concept of a percutaneous valve. This is the valve that he made in his kitchen with some malleable wire crimped onto a balloon. It was 41 French. He put it in a number of animals, and in fact, in 3 of the 10 animals, the valve was in the subcoronary position, so it was really the first TAVI. He couldn't get the paper published for forever, but finally in 1992 it was published, and then he sold the patent for the technology of percutaneous valves for $10,000. This year it is estimated that it's a $17 billion business. So much for selling your patent. Nonetheless, the intervention on the right ventricular outflow tract was really began with Philip Bonhoeffer in 2000. He had been working with stenting conduits that were obstructed, and he came up with the concept of putting in or sewing into a metal frame a Contegra graft, which is a bovine venous valve. And this is what we are familiar with the so-called Melody valve, which was the first major device that was used in the right ventricular outflow tract. Now, speaking about the patient population that we can address is understanding the difference in the right ventricular morphology. So it can be actually broken down into 2 large quantities. One is the tetralogy with pulmonary atresia or the coronal truncus patients who need conduits, and these can be primarily addressed with existing technology, the Melody valve or the Sapien valve that you're well aware with, and even bioprosthetic implanted valves can be addressed with these technologies. But that's only about a quarter of the RVOT population that we see. 2/3 of that population really are patients who've had transannular patches, and a small number of patients who develop severe pulmonary insufficiency after pulmonary valvotomy, whether surgical or by balloon, are a different morphologic issue that has to be addressed. And the challenges that we faced when we were trying to think about the types of valves that you could use in a percutaneously, it was the problem with the various morphologies that we were seeing. This is a paper from Philip Bonhoeffer when they were looking at the population of patients who had significant pulmonary insufficiency and the morphology of their right ventricular outflow tracts to really design a concept where you could address these various morphologies, or at least the majority of these morphologies. So that was the first challenge. The second challenge was an understanding that developed very quickly as we were investigating these various implants, is the dynamic nature of the right ventricular outflow tract. Now, you're all familiar with changes in ventricular dimensions during the cardiac cycle, but it became very clear that the elastic properties of the main pulmonary artery, the annulus, and the branch pulmonary arteries changed dramatically during the cardiac cycle. Not only did they change in dimension, as you can see here, but there was also a twisting phenomenon that occurs during ejection. So that was one problem. So one of the early approaches was that by, again, Philip and Kurt Amplatzer, who came up with a concept of some kind of a filler that you could implant in the outflow tract. It would be a landing zone or would have a valve attached. And that sort of evolved into the concept of a self-expanding implant that you could implant in a wide ventricular outflow tract of the main pulmonary artery that would sit in place with a valve inside it. So over the course of a number of years, a number of designs have become available, and these are the four major designs that are clinically applicable now, up to diameters of the main pulmonary artery of up to 38 millimeters. The Harmony valve seen here and the venous P valve seen here are available in Canada. The Altera adaptive pre-stent is really just a stent, is available also in the United States, and the Polster valve is available in Europe and Southeast Asia. So I want you to think about, as we talk about these valves, are there areas where one valve may be more clinically applicable? And perhaps there might be a subpopulation where one valve would be better than the other. So I just want to take perhaps a deeper dive into the morphology of the outflow tract and each of these valves. Now, the Altera pre-stent, as I mentioned, is a stent that doesn't come with the valve here. It's a nitinol framework where the nitinol is soldered together, so it's fairly stiff. It's designed as a dog bone where you implant it in the outflow tract, and then you implant the sapien valve, 29 millimeter sapien valve within it. It's all done at the same procedure. The diameter of the unconstrained implant is 40 millimeters with a 48 millimeter length. A slightly different concept, but within the same general thought of how the device adheres to the main pulmonary artery, is the Harmony valve. It comes in two sizes. This is the Harmony 22, so it refers to the valve casing, which is 22 millimeters in diameter, and bovine valve leaflets, and the Harmony 25, which actually has a much more a greater application because of the outflow tract diameters. And this valve is 25 millimeters in diameter. It's 43 millimeters in diameter in the outflow. This would be the confluence of the pulmonary artery end. This would be the inlet or the RV end, and it's 54 millimeters in diameter. And I'll talk to you about how we choose the sizing and the effort and how we determine that the implantations would be safe. A slightly different valve is the venous P valve, which just recently became available in Canada, and we've had an opportunity at Toronto General of implanting several of these. It's a porcine valve where it's not a dog bone kind of configuration. The diameter here fills up the entire main pulmonary artery, and as you can see, it's useful up to diameters up to 36 millimeters, which would be this diameter where the valve housing would be. and it comes in a variety of lengths in order to accommodate the outflow tract anatomy up to almost 70 millimeters in length. It too is a self-expanding nitinol framework, also soldered at each one of the connecting points, so it's relatively stiff for the implantation. The final valve that I want to mention is the Polster valve, which is a completely different concept in terms of the framework of the valve, and it's really a weave of self-expanding nitinol, so they are not soldered, so it's a little bit softer, and it tends to rotate or twist during ventricular systole and untwist during diastole. It too has the same concept as the venous P valve to fill up the entire main pulmonary artery. So when we talk about the implant and how it's positioned in the valve, it's actually, for example, you can get a valve that is actually 32 millimeters in diameter. So when you think about these four valves, they actually can be grouped into two large categories as to how they're implanted into the outflow tract. So things about when you think about the Altera concept or the Harmony concept, the stability of the valve depends on the dog bone configuration filling up the outflow tract and being compressed by the main pulmonary artery. So one has to determine from imaging what the various diameters are along the main pulmonary artery so that the adherence points will allow stability of the implant, or what the engineers call interference. So the valve housing itself does not touch the main pulmonary artery. So here's just a model of an outflow tract, and the Harmony valve. So it's attached to the distal end and the proximal ends of the outflow tract, and the valve housing sits here. Of course, the Sapien valve is bovine pericardium, and the Harmony valve, which sits inside here, is a porcine pericardium. Now, when we look at the other two valves, the Polster or the venous P valve, very different concept of how the valve adheres to the main pulmonary artery or the landing zone. And essentially what happens in the decision making of picking the size is that you pick the size based on the diameter of the outflow tract, and then the valve implant itself is that diameter. So here's a venous P valve that sits entirely inside the main pulmonary artery, and then the valve housing is here, and here's a Polster valve, a similar kind of concept where it expands against the outflow tract. So how do we assess for a potential transcatheter pulmonary valve implant? So of course, we must meet guidelines for pulmonary valve implantation. So we do not believe that if it's not a surgical candidate, then it's not a candidate for a percutaneous valve. The guidelines apply to both approaches. The screening for one of the valves really depends, of course, as I mentioned, on the outflow tract anatomy. And the best screening approach is an MRI study, which is often needed to determine the need for a valve based on the guideline criteria of right ventricular volumes. And you can see again how dramatic there are changes in the outflow tract. And it's important when you're making the screening measurements to make sure that you make the decision based on ventricular systole, so you see the largest diameter of the main pulmonary artery to determine whether or not one of the valves would fit. Once you've gone through the concept that the MRI suggests that this might be appropriate, then more detailed imaging is required, and what we recommend is a retrospective ECG-gated CT scan in order to determine the diameters of the outflow tract at the minimum and maximum parts of ventricular systole, so at 30 and 90% of the cardiac cycle. And this is just a reproduction from a CT scan, which shows the diameter during diastole and the diameter and length during systole, which again, very dynamic and has to be taken in consideration when you're picking the valve. And this is just a three-dimensional reconstruction of that image. What's very important and what the engineers, when they do the fit analysis, let us have to make the decision on whether or not a valve would be appropriate is to measure along the outflow tract the diameters during systole and diastole. Now on this panel on the left is the silhouette of a Harmony 22. Again, the diameter of the valve is 22 millimeters. And here's the silhouette in black of the Harmony 25. Red is the diameter during ventricular systole. Blue is the outflow tract diameter during diastole. You can see it changes quite a bit. And in order to be secure with this kind of technology, and this applies to the Altera as well, you want to have a certain degree of compression of the arms during systole and diastole. It's 15% here and 17% compression in the outflow tract in order to know that the implant would be stable. The venous P valve is very different in its the things that you use to determine whether or not it's appropriate. You actually have to do an in vivo balloon sizing in order to identify a choke point or a narrowing, which can't be larger than 36 millimeters. That's the largest diameter valve. With this kind of valve, however, because you're expanding the outflow tract, it does make the issue of coronary artery compression important, and that has to be considered when you're thinking about using this kind of valve technology. So this is just an example of one of the patients, a 28-year-old woman with Phillo's tetralogy, went through this standard management, transannular patch, severe RV dilation, and PR. This is her CT scan, and I'm going to show you the Harmony assessment. And what they are able to give us in the analysis is actually a landing zone diameter, so you can get a good apposition if you have the distal arms of the device either within this landing zone and still have a very stable implant. Again, the same kind of diameter plot for the device, looking at how much compression there would be during systole or diastole, and you can see that there would be, and this is the 22, which would fall out. It's because the outflow tract's too large, and here's the 25, and they're just positioning it in different locations along the outflow tract to see if it would be stable. So if you start right here all the way down to about here, there's a stable apposition both in the outlet and in the inlet. And these are just some slides from that patient's valve implantation. It's a 26-French long sheath that's placed into the outflow tract. It's just a photograph of the main pulmonary artery and the branch pulmonary arteries, and this is an AP projection in the cranial, slightly LAO, or slightly RAO projection to see the branch implantation, the branch location to help us this, in device location. And this is the lateral projection. Here we've maneuvered the device into the outflow tract, and then we're going to start to retract the outer sheath to open up the distal arms, as you can see here on the lateral projection, and you can see on the AP projection. And we're just pulling back the sheath a little bit more, but very slowly, to make sure that we don't move the device into the too low into the outflow tract. This is a slightly different patient, but you can see how the middle rows of the self-expanding nitinol are exposed as you retract the sheath. And then finally, in this patient, we're going to remove the attaching mechanism of the device to the delivery cable. And then here is the final implant showing good apposition and no pulmonary insufficiency or paravalvular leak. Now, I just want to go over with you what is known about these percutaneous valves. The most studied valve so far is the Harmony valve from both the early feasibility study, which Eric, Mark, and I participated in, their pivotal trial, and the continual access study. So this population is followed for 10 years, and this is the 2-year follow-up data on the cohort for this Harmony implant. So the ages, if you just look at this column here, median age was about 29 years of age. Most of the patients had Fallot's tetralogy with severe pulmonary insufficiency due to a transannular patch, but not an insignificant minority had valvular pulmonary stenosis with after a surgical or a balloon dilatation. So no mortality in the 25, the TP25 population. There was one death at 1 and 2 years, one due to pneumonia and malignancy. We had one death in the early feasibility study, one of our patients who died of a myocardial infarction a year after the implantation. But for the continual access study, no mortality related to the device or the procedure. Thrombosis on the device did occur at year 2 on the 25 millimeter implant in 2 patients. An atrial fibrillation in 2 patients at 2 years. But more interesting, and not to be unexpected, but more interesting is with the 25, we had an incidence of ventricular tachycardia often immediately during the implantation or within the first 24 hours in patients in which the valve was transannular. So those inflow struts were up against the outflow tract myocardium, at least posteriorly. And these patients, 11 patients of the patients, had ventricular tachycardia, all very self-limited, treated with a short course of beta blockade with no recurrence after 3 months. So what about the function of the valve? As you can see, at 2 years, in both the 22 and the 25, very, very low incidence of recurrence of pulmonary insufficiency. Only one patient in the population with 25 had moderate, the remainder had none. Similarly, in the 22 millimeter implant. Paravalvular leak is a problem, as if you don't get good apposition to the valve, around the main pulmonary artery, that's an issue. Non-existent in the 25 millimeter application as this expands against the main pulmonary artery. Mean gradients across the outflow tract, pretty stable, not clinically significant through the first 2 years in both cohorts. And this is the appearance of the echocardiogram at 2 years in one of the patients. I think this is an intracardiac echo study. You could see that the leaflets appear very thin and mobile. You can see the outline rather of the implant. So this is the ventricular side. Here it's against the ventricular myocardium in the main pulmonary artery, and then adherent to the distal confluence. Since the Harmony valve is made out of struts, there's nitinol struts, the question about stent fracture comes up. We had stent fracture in the 22 in the early feasibility study early on with a very low implant, but no stent fractures in the patients in follow-up with the newer design, the larger TP 25 millimeter implant. Valve dysfunction also was at 95% of the patients did not have any valve dysfunction at 2 years in the 22 and 25. This was an earlier design which was changed because the distal flange was too abrupt and didn't adhere to the wall. This model is not available. So valve dysfunction is very unlikely or unusual. I think the important issue is, has there been any need for reoperation or reintervention in the cohort? Freedom from any catheter reintervention in the 22 is 100% freedom from reintervention. And there were 3 patients in the 25 cohort that required one a Melody valve and 2 patients a Sapien valve to be implanted within the valve housing because of early valve dysfunction. So fairly good 2-year follow-up of absence of freedom from reintervention. And then finally, and most interestingly and gratifying, is that the patients actually felt better. They on their SF-36 questionnaire, their physical functioning was characterized as better than their initial cohort, as well as their improvement in their exercise tolerance and overall general health. The similar kind of data is available for the other, but perhaps more limited, for the other valves. The Altera preset in their feasibility study also was absent from significant regurgitation or outflow tract obstruction. The Poster valve and the Venus P valve also very similar profiles in terms of valve functioning and a gradient across the outflow tract in follow-up, although a little bit more limited in patient numbers in depth. So just some closing remarks. Despite what have to be evolutionary changes in percutaneous valve technology, challenges do remain in implementing the strategy. Understanding the impact on the function of the right ventricular outflow tract is something that's relatively stiff, but long and stiff, as opposed to a bioprosthetic valve, which has which is limited to the sewing ring. The problem with heterogeneity of the patients with congenital heart disease and the varied surgical repairs creates a challenge in the variability of the outflow tract anatomy, and this still has to be addressed for those patients that may not be good candidates for the existing valves. Newer devices targeted to reduce the effect of RVOT have shown promise, as I outlined with these follow-up data, but we're still limited by certain dimensions, as depending on the diameter of the outflow tract, up to 38 millimeters for the existing valve technologies. And we have to look towards further innovation for selection of these devices to accommodate a wider range of outflow tract anatomies. Unfortunately, small patients, many in the pediatric population, were excluded because of vascular limitations. These are very large profile delivery systems, which make implantation in a small child difficult, or perhaps even in a good way avoidable. The short and midterm outcome data is good, shows promise, but these are only observational and still need further detailed assessment. I have to say there's no RCTs for percutaneous for surgical PVRs, and I have to say probably never will be. Long-term durability and function. Long-term durability has yet to be proven. Larger studies are required. And finally, the RVOT management strategy that we used to think about repeated percutaneous valve-in-valve procedures, while technically possible, it hasn't been demonstrated because the valves haven't been out that long. But reminding everyone that saving a patient 2 open heart surgical procedures avoids a series of multiple reoperations, quality of life issues, increased financial, emotional, and social costs. And from a healthcare perspective, it's been estimated that saving 2 heart surgical procedures in the United States saves $300,000 per patient. So with that, thank you very much.
Thank you. As usual, excellent talk and fantastic overview. So if you want to make any questions, either you can write the questions in the chat or just open your microphones and you can ask the questions directly. So there's a question in the chat already from Marcus Schwartzman that you know. Marcus is in Ottawa now. And Marcus say, thank you for the very interesting overview. Does the implantation of these devices, especially the ones with the struts in the RVOT, affect the success of a radiofrequency ablation for patients that can have a VT? And if yes, should we do EP studies in selected patients prior valve implantation?
I can't answer that question because the data is not in. I know that at UCLA, they're doing EP studies on all their tetralogy patients before pulmonary valve implantation. Certainly, there's a debate amongst the electrophysiologists on whether or not you should do a standard EP study prior to intervention on this population. But the question of whether or not the struts of the device will interfere with a further intervention if the patient develops ventricular tachycardia along that area of what they call SCAI, where the outflow tract infundibulum is the etiology of the ventricular tachycardia. I'm not sure I can answer that question. Those patients have not had to come to the EP laboratories yet. Hopefully they won't have to, but it is a concern among some EP physicians about the problem that might cause.
So just following that comment that you meant about UCLA, UCLA is doing what? UCLA is leading now a study with their actually is a control trial with EP and no EP prior pulmonary valve implantation. So Jeremy Moore is really leading this field now, and I think we would have short answers, or answers shortly. But I really share with Marcus the concern that we are just covering one of the known isthmuses of the VTs that we might not be able to access afterwards. But so Erwin is next question is from Erwin. Say, fantastic talk. What about the risk of endocarditis with the newer generation valves? Do we have any information about that? Because we're always concerned about that the patients with percutaneous valve has more endocarditis, which has been true for the Melody for I think reasons that we can discuss, but probably it's just a small valve with a lot of high gradients after the valve implantation that probably has led to that publicity that the Melody has increased endocarditis. But do we have any real data on these new valves about endocarditis?
Well, so far there has been no endocarditis on the Harmony valve in the continual action study follow-up. Just to remind everybody that the valve leaflets are different from the Melody valve. The Melody valve are contegrographed, the bovine venous valve, in a different environment than the right ventricular outflow tract of a patient with tetralogy of Fallot. And the valve leaflets are actually the same material as used in the bioprosthetic valves. So I think that one would expect probably the same endocarditis risk as a bioprosthetic valve. And just to go back to the last question, we try very hard to implant the valve in a superannular position. So the inflow portion of the valve is above the valve annulus, so that we don't cover that infundibular portion.
That's important. I just following there's a question from Grisham, but before going to that question, just to follow on Erwin's question, how much do you think that the valve or what the material that the valve is made of is the responsible for the endocarditis, or it's just the valves that are small and we live with high gradients, which is almost always the melodies. The high gradient is one of the main risk factors, which has been proven in several studies that
That's
might
right.
increase the risk of endocarditis. With these valves don't have high gradients because they are so huge that you never have a residual gradient in the outflow tract.
Well, I guess that goes towards what is the mechanism of endocarditis on a
Yes.
implantable valve. And in the high end, I mean, it happens on all valves in all positions. But I think that the issue of the kind of environment that the Melody valve was going into is very different. So the Melody valve is going into most often pulmonary homografts that have become both stenotic and regurgitant. And these valves, these conduits have these intimal layers of fibrin tissue, a very nutrient environment for bacteria or potential for bacteria. So I think that by implanting a metal valve with these bovine venous valves, and as you say, the gradients cause the turbulence in the valve leaflets, which set up the
Environment.
environment. Yeah.
So it's another question from Grisham from Glasgow in Scotland. So Lee, thank you for your thoughtful talk. May I ask you a philosophical question regarding the choice of valve? So first, timing of surgery versus transcatheter as first option. And second, what is your philosophy on stretching homographs beyond the nominal implant diameter?
Two questions. Okay.
Yeah,
So,
two questions. First question is when we should do the first percutaneous valve, and that actually was, I had that question in my head. Should we go for it when you are 20, or we should do the first PVR when you're 20 and go for the valves afterwards?
Yeah, so I mean that's actually two different questions.
Yeah.
I think first of all, I think the decision to put a valve in has to be based on guideline criteria. So you need a valve. Okay, so, and there is some data, some recent data that suggests the earlier you put a valve in other words, that's a moving target the size of the ventricle. It used to be 180. Some people do it at 150 in terms of the end diastolic dimension. The earlier you put it in, there's a greater likelihood of reverse remodeling of the right ventricle if that's your goal. Then there's the philosophy of never let the right ventricle dilate. There's a group that think about, well, what should we do for these patients who have transannular patches and pulmonary insufficiency? Can we use existing technology to avoid the RV dilating, or at least be able to go in very early and put a valve in? And I have some colleagues who said, well, when you're 7 years old with tetralogy of Fallot, asymptomatic, non-dilated, well, not a massively dilated ventricle, go in and put a surgical valve in. And then we would take care of that for the next 30 years. Never let the RV dilate up significantly. Then there's a group of people who suggest, well, let's not put a valve in, but let's put a bare metal stent in the right ventricular outflow tract before that dilates up. And then at some point in time, you can have a landing zone for an existing type of percutaneous valve, such as a Sapien, for example. So you don't have to go through the rigmarole or the issues of these big dilated main pulmonary arteries. So I mean, those are ways of thinking about what you should do. I don't have the right answer. I know I used to think that I wouldn't want the right ventricle to dilate. I was a very strong proponent of early intervention, and data from from the hospital for sick children that we did with the Melody valve in conduits showed that exercise performance improved in the population that you did an early intervention and put an early valve in compared to the older patients who the ventricle had dilated up more. So I don't have the right answer to that, but or even an answer to it, but I think that it will be something that's under study from a number of different units.
And do you think that if when you go for if let's say we don't discuss indication, we assume that we accept the patient needs a valve, when we should go for a percutaneous valve or surgery? Should if
Okay.
the question is if a percutaneous valve option is available, should we go for a percutaneous valve as a first option in a young individual?
I understand what you're saying. There is a lot of conversation about that the first valve should be a bioprosthetic valve, and then you take care of the bioprosthetic valve thereafter. Um, there, I think it depends on what valve you intend to implant and what the lifespan of a percutaneous valve would be. Let me give you a scenario. You're 18 years old. You need a pulmonary valve. You put in a harmony valve. It lasts for 20 years. Now you're 38 years old. You have a landing zone that's 25 millimeters in diameter that can go up to 30. So you put in a second one, or let's say you put a sapien in, or even a second harmony valve. Let's say you put in a 29 sapien inside that. That lasts for 20 years. Now you're 58 years old. So now the surgeon has to deal with taking that large outflow tract out. We don't know how difficult that will be, and I think it varies depending on what kind of valve you put in. Personally, I like the Polster valve because it's very short and it fills up the main pulmonary artery. I suspect that if you put another valve inside that, when you're 60 years old and need to have it taken out, maybe it will be a surgical, it won't be a surgical nightmare. But that's all very theoretical. I mean, there are colleagues of mine who say, well, you put in one of these large valves, it should outlast the patient because you can revalve it 3 times. So we don't know what the data is. There's a lot of hypothetical conversation about that.
I'm going to the second question from Grisham. What is your philosophy on stretching homographs beyond the nominal implant diameter?
It depends on the homograph, and there's a lot of calcification. If you could probably get it up 10% larger than the nominal diameter safely, if there's not a lot of calcification. If it's very heavily calcified, pretty scary to stretch that without putting in a covered implant.
I think the next question is from Dr. Sasi Kumar. I think that you already answered this question. Thank you, Dr. Benson, for the excellent overview. Has the finding of a VTAC changed the implantation strategy? So a patient that has a ventricular tachycardia prior to the implantation, would you change the strategy and would you implant the valve as high as possible in the PA? I think that you already said that you try to do that regardless of whether or not the patient has a ventricular tachycardia.
Yeah, and just like a surgical valve implant strategy, if the patient has VTAC, you're going to go to the EP lab and have it mapped out to see if they can ablate it. So, I mean, it'll be the same strategy.
So I just in the last 5 minutes, I have another controversial question. What would be the approach of a patient that comes with a percutaneous valve, endocarditis, and they have significant PR? You treat the patient. Would you put another percutaneous valve on a previously infected but clear as can be, right? With 6 weeks of antibiotics and no signs of active infection, would you consider to do another percutaneous valve? And if you would be your timeline that you think would be safe to put another percutaneous valve within a valve that had an infection?
Right, there's no real data in these newer valves, but there is data in the Melody valve. Mark Gewillig has published on this, and they have revalved these patients after medical therapy of endocarditis. So it's Melody valve implantation. And my recollection is they treat them for 6 months. And then they go in, assuming that it's not hemodynamically compromising the AI, that they go in and they revalve these without recurrence of the endocarditis. And that's in the literature. So it's doable.
Yeah, so you know how scared I am of that, so that's why.
Yeah, I know, but it's like that.
I-
Fear is
no,
nothing
no,
I
well,
can do.
I think we need the data. Don't get me wrong. I think we need the data. I think that we assumed the worst all the time, and we don't have data to assume either way. So it's good that people that are doing it, we should encourage everyone that are doing these things to publish, because that's how we learn. And
Yeah.
and
Well,
that's
we only have, the only thing we have to fear is fear itself.
yeah, exactly. We are biased to our practice, right? So okay, so anybody has any other questions? Okay, if there is no more questions, really thank you very much for the excellent
Thanks
talk,
very much, everybody.
excellent overview, and I thank you everyone for joining us, and see you here in 2 weeks, and good morning, good afternoon, or good evening, wherever you are in the world. Thank you very much. Bye.
Thanks a lot.
Bye,
Bye-bye.
Lee. See you. Bye.
Bye-bye.
Bye-bye.